We are going to go over directed cough in this video. Probably the most common one that you're going to educate patients on is going to be the forced expiratory technique or the Huff Cough with some chicken arms or some chicken wings. It's just pretty user-friendly, pretty easy to understand. There are lots of things that kind of fall under that directed cough. It could be the mechanical insufflation-exsufflation device, the MIE. The brand name a lot of times is the Cough Assist for that one. It could be other techniques like talking about autogenic drainage or active cycle of breathing that can help with a cough. Those are a little more involved, complicated. Forced expiratory technique just tends to be one that's pretty easy to give to patients unless they're in a special population where they might need one of those more advanced techniques. Manual assisted cough, MAC, also known as the quad cough, also falls under this category, but that would be for a special patient population, neuromuscular disease, paraplegia in some cases, quadriplegia, those people that don't have good control over their diaphragm for a cough. Those can tend to have some pretty serious complications or hazards. So if you're able to help patients in that population cough with an MIE, that can be preferred because there are just some hazards and complications. We are going to talk about indications for directed cough. So for indications, first and foremost, we're trying to remove retained secretions. If the patient has the presence of atelectasis, they might be more at risk for mucus plugging. So that would be an indication for directed cough education. Prophylaxis post-op, a lot of times those post-op patients, even if they're uncomplicated, will have that cough and deep breathe order to make sure that they're using their lungs effectively and keeping them open and moving secretions that might be retained because they're having pain. Routine part of bronchial hygiene, so when we do postural drainage, percussion, vibration, vibratory PEP or oscillatory PEP therapy, we want the patient to cough afterwards. We're doing the therapy to move the sputum, so we want them to cough. We may also do directed cough to obtain a sputum sample. Contraindications, it is really rarely contraindicated to do directed cough with a patient. We have to worry when there's a possible transmission of infection. So if it is an airborne precautions patient, if it's a droplet precautions patient, we just want to make sure the appropriate precautions are being taken. If it's a TB patient and you're doing directed cough with them, you want to be in a negative pressure room. You want to be wearing an N95. You want the patient probably to be wearing a mask to decrease the issues. Increased ICP, I always tell my students that's like a contraindication or hazard for like almost everything we do in respiratory. Reduced coronary artery perfusion. So that is a patient having an active MI, myocardial infarction. When we cough, we compress the chest. And if you already have a heart that isn't getting all the blood flow that it should, and we're compressing the chest even further, we're going to make it worse. So I can't think of a time where I would be doing a directed cough with an MI patient that hasn't been reperfused yet in the cath lab. And then unstable head or neck injury. We're not asking people to if their neck isn't stable, okay? Hazards, there are many, many, many hazards to directed cough. Reduced coronary artery perfusion. So we're already reducing the coronary artery perfusion with a cough in some cases. Reduced cerebral perfusion. Have you ever been sick and coughed so much that you saw stars or your eyes went black for a small period of time? You were reducing your cerebral perfusion. Incontinence, especially those mamas that have had babies. You get into a coughing spell and you can have a spell of incontinence. Not just mamas, but that's a really common one. Fatigue, you could make them tired or they're already tired and you're just adding to the load. Headache, numbness, bronchospasm, discomfort, spontaneous pneumothorax, cough paroxysms. So you can actually send them into a coughing spell by doing a directed cough with them that they're not able to control. chest pain, rib fracture, incision pain, or evisceration. That means the surgical site opens up. Vomiting, visual disturbances, retinal hemorrhage, central line displacement, GERD, there's a lot of them. As far as like the pain, the incision pain, we would recommend splinting to that patient, or we may coordinate with nursing to get pain meds on board, and we would splint to make sure that the patient is doing what they need to do to stay healthy. So splinting is going to be, let me get a pillow. Splinting is when we use something like a pillow, a blanket. If they're a heart surgery patient, some hospitals have this little cutesy heart pillows that they give people to hug. The clinical word is splinting. So you would want to hold the pillow. If I had what's over here, your liver, some kind of liver surgery, and I had an incision, you would want to hold the pillow against the incision site when doing the directed cough, because it's going to keep that incision site only from moving too much. So when we, it's still allowing everything to expand except for that spot with pain. It should reduce the pain for the patient and help them have a more effective cough while still protecting the painful area. So I would do all of the things you would normally do. I would check the chart for an order. I would review the patient chart. All of the normal things we would review in the patient chart. When I enter the room, I would say, "Hi, Mr. Howell, I'm Jen from Respiratory. We are going to do some cough therapy with you today to help you get the secretions in your lungs moving and hopefully get them up and out. Can you tell me your name and your birth date?" He would tell me his name and his birth date on his armband. He's a mannequin, he's not going to be able to tell me. I would assess him the way I would assess any other patient that I'm coming to deliver therapy to. Visual inspection, I'm going to look at his color. Does he have signs of cyanosis? Is he nasal flaring? Is he sweating? Can I see any retractions that are obvious while I'm just doing a visual inspection? I typically will give a patient's foot a squeeze when I go by the bottom of their bed to see if they have any edema, pedal edema. I will probably look for digital clubbing when I'm looking at their wristband. What position are they in? Are they tripoding? Are they holding on? I think that pretty much covers visual. I would look at vitals or take vitals, the 5 vital signs: heart rate, respiratory rate, pulse ox, blood pressure, temperature. I would listen to my patient, auscultate with my stethoscope. I would palpate and percuss. So I might do butterfly hands to see chest rise. I might feel for some tactile fremitus or bronchi fremitus. I would percuss my patient to see if there are any hyperresonant or dull tones. I would ask the patient how they're doing. The patient's subjective answer is important. I would ask them if they've been coughing, if they've brought up any phlegm, if it's typically little tissues are on the bedside table in the bed. There might be a basin. I would look to see what the sputum might look like or ask the patient if they're able to tell me. And then I would get into the cough education. Okay, Mr. Howell, we're going to work on a cough that can really help you bring up some phlegm. So it's called the Huff Cough, and you'll see why. It might seem silly, but it really does help bring up the phlegm. So what I want you to do is, I have my patient pretty much in high Fowlers. I don't actually think my bed goes up any higher than this. Let's see. Oh, it goes up a little bit higher. You want your patient sitting up in bed, sitting in a chair, high Fowlers, semi-Fowlers, a good position so they're able to get that maximum drop of their diaphragms and good movement. Okay, Mr. Howell, I'm going to show you the cough and then we're going to try it together. So what this does is it helps get your airways open, it helps get all that air behind that phlegm to get it up and out. Don't laugh at me when I do this because it's going to look funny. What you're gonna do is take a deep breath in through your nose with a little bit of a breath hold, and then you're gonna perform some huffs with your mouth open. Your air is coming out of your mouth. It's gonna look like this. You're gonna do that 2 or 3 times. So I'm gonna do it 2 more times. Then we're gonna get a big cough in at the end. So after I do those sets of huffs, I'm gonna breathe in through my nose, hold it, and then get a good cough behind it. Now I almost kind of put chicken arms in just without even thinking about it. What we can do with that cough to give it that extra punch is after we do our huffs, 2 or 3 sets of those, when we go to do our cough, we can raise our chicken wings or our chicken arms and use them to push that air out even more, give it a little extra punch. You're gonna wanna make sure your patient has tissues at the bedside or a basin to spit into or a yank hour to suck the sputum out of their mouth, because the whole point of doing a directed cough is to get that sputum up and out. So I have a tissue here. Let's give it a try together. And I would go through the steps again. Okay, take a deep breath in through your nose, and then you're gonna open your mouth and you may have to remind your patient to do it away from you because they will cough right in your face. Okay, that was good. Let's do another round of huffs. Okay, do you wanna do one more round of huffs? That would probably be good. Okay, now we're gonna do the cough. You might wanna add your chicken wings to get that extra punch in there. You would have him cough. Okay, how did that feel? Did we bring up anything? I would probably wanna look at it because I wanna document sputum. We may do another round of the Huff Cough. Now this is a cough you can use all on your own. Nobody has to come in and tell you to do that. If you feel like you have some phlegm down there that isn't coming up, give the Huff Cough a try. This is a good cough to use when you feel like you have phlegm in your lungs. I would reassess him for all of the things we assessed in the beginning. I would document date and time, most importantly, what cough I taught him, how was his effort, was he able to understand me and demonstrate it, what his cough brought up, sputum characteristics, amount, consistency, color. It may have an odor, especially Pseudomonas, may have an odor. Whether I think the patient needs re-education on the Huff Cough or needs help the next time he does it. A lot of times Huff Cough, like we talked about with indications, is used in conjunction with a vibratory PEP or maybe even chest PT with vibration. It's kind of an integral part. You know, we're doing these therapies to break up the phlegm. We want to make sure we get the phlegm up and out. If we don't with a directed cough and we still have signs that there is retained secretions, then we would probably have to graduate to some suction, which we'll learn about later. I think that about covers it. There isn't a specific checkoff or skills test for directed cough, but it is part of chest PT and vibratory PEP. So I would expect to include that in a skills test on those 2 skills. Okay, have a good day.